I am delighted to introduce Professor Beverley Hunt, who I'm sure for many of you doesn't need any introduction, but Beverley has been the founder of Thrombosis UK and Professor of Haemostasis at Guy's and St Thomas's. She's a national and international expert in thrombosis and acquired bleeding disorders, and of course has sat on multiple national and international guideline writing groups and has extensive clinical experience of thrombotic disorders. Of course, she has been very familiar with managing patients with antiphospholipid syndrome over the years, and certainly being a colleague, we've discussed many complex cases together. So I'm just going to hand you over to Beverley now, who's going to discuss obstetric antiphospholipid syndrome diagnosis and treatment in 2023. Over to you, Beverley.
Thank you very much, Karen, and it's really lovely to be a co-chair with you today. I am going to discuss obstetric antiphospholipid syndrome. The title of the symposium is an update in evidence and practice, and there really has been very little new evidence in obstetric APS. So I'm really going to concentrate much more on management and the protocol that we use at Guy's and St Thomas's and have used and developed over the last 20-30 years. Next slide, please. Next slide, please, Joe. So as I'm the first, I'm going to remind you how when you detect antiphospholipid antibodies, we have to have 2 positive tests of the same type of antiphospholipid antibody 3 months apart. And we are testing under current guidance for 3 different tests: the dreaded lupus anticoagulant, the anti-cardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies. And the other issue about the antibodies is they interfere with a lot of thrombophilia testing. You can get low functional protein C antithrombin, and classically they cause a low free protein S because they interfere with the binding of protein S with its carrier protein. Next slide, please. And of course, we separate out antiphospholipid syndrome from all the other thrombophilias. Remember, the definition of thrombophilia is predisposition to venous thromboembolism. APL is different. It can cause a clot in any vessel. And for obstetric APS, we particularly worry about placental clot. And there's some general rules about APS. Once you've had a clot in one vessel, it tends to occur in that same distribution. So if you present with a stroke, you tend to have recurrent stroke. And the other issue, which makes management really difficult, is if you have a woman starting out in pregnancy and she's never had a pregnancy before, you don't know whether her antibody is going to cause problems or not. Next slide, please. So the other issue is that with antiphospholipid antibodies, there's another mechanism that causes problems in pregnancy. So we know we see thrombosis in the placenta, but you don't develop a placenta until 12, 14 weeks. And yet we get recurrent first trimester loss. And the mechanism causing that loss is thought to be inhibition of growth of those early cells. And we've got evidence for that from human cell lines and the mouse model. Next slide, please. So if we go right back, way before the definition of APS in 1986, we have got a lot of publications talking about the presentation of fetal loss, usually in the 2nd and 3rd trimester, tiny growth retarded babies, and then they looked at the placenta and we see extensive thrombosis. So that's always been the classic presentation of APS, but actually it's quite uncommon. And if you sit in clinic, you are mainly dealing with recurrent first trimester loss. Next slide, please. So when we just look at this mechanism of placental thrombosis, would you just move the slides through, Joe? We get placental dysfunction, and that can be We have a small baby because it's getting inadequate nutrition. The worst case scenario, we get fetal loss, but we can also get preeclampsia. So, and what's so interesting about placental dysfunction, in some women, it causes preeclampsia. In some women, it causes small babies, and in some women, it causes both. Next slide, please. And we know that with antiphospholipid antibodies and placental dysfunction, it can start affecting very early the development of the placenta. So the early development of the placenta means that we get downgrowth of the placental endometrial cells into the spiral arteries, which are going into the placenta and delivering blood. And that doesn't happen so well if you develop preeclampsia or you have placental dysfunction with APS. Next slide, please. And when we look, so we had Sophia Stone, who's now an obstetrician in the West Country, did placental bed biopsies as part of her MD, and we found that this is a cross-section of the spiral arteries delivering blood to the placenta, and you can see we have got what we call acute atherosis. We've got growth inwards of the cells, so we've got a tiny little spiral artery not delivering enough blood, and we also have acute atherosis, which means we've got lipid-laden foam cells in that area as well. And we only see this in antiphospholipid syndrome and preeclampsia due to other causes. Next slide, please. And we have some interesting animal data saying that if we deliver an antiphospholipid antibody to a pregnant mouse, we find that if we block complement activation with a monoclonal antibody or with heparin, because heparin is such a good anti-complement molecule, we will block the loss of the fetal mouse and we will prevent placental dysfunction. New paragraph, please. Sorry, new slide. And so looking at complement activation, part of Karen Breen's MD was to look at the extent of activation in the different types of antiphospholipid syndrome, just to see if there was any evidence of increased complement activation. Next slide, please, Joe. And Karen found that there was some evidence of increased complement turnover in those who had obstetric and thrombotic APS. And really this story about could it be that in humans complement activation is mediating placental problems hasn't really been taken much further since then. Next slide, please. So let's get back to being practical. We define obstetric antiphospholipid syndrome with 3 different types of phenotype. So we've got recurrent first trimester loss, and that means 3 losses in a row. We can't have a normal delivery or anything like that in the middle. They have to be 3 first trimester losses with no other cause found. Or we can have a pregnancy loss in the 2nd or 3rd trimester. So that's the original description. And lastly, which tends to get forgotten, is that premature delivery of a baby due to placental dysfunction before 34 weeks gestation. So a woman with really bad preeclampsia requiring to deliver her baby before 34 weeks, or a very small baby, or occasionally placental abruption. Next slide, please. So back to this issue, which makes managing women with antiphospholipid antibodies really difficult. We can't predict how they're going to behave in pregnancy. Some might have recurrent miscarriage, some might have a late loss, or some might have nothing. And we know that if they've previously had thrombotic events, they are more likely to have obstetric APS. But if we had 100 women with antiphospholipid antibodies most of them would have a normal pregnancy. And we can have a little look at the antibodies and say, well, lupus anticoagulant maybe is more likely and high titer is more likely to cause pregnancy problems, but we're still stuck with the problem. We can't say for an individual how things are going to go. Next slide, please. So let's just think about what risks we've got in the pregnancy. So the mother, we're worrying about increased risks of thrombosis. Pregnancy's a prothrombotic state. They've already got an antibody. It's a recipe for thrombosis. And we know also that 10% of our pregnancies have preeclampsia if we leave them untreated. And then we have the horror of some of them might have lupus as well, and we might have to give them prednisolone and other drugs. For the fetus, we've got, do we have a risk of first trimester loss, or do we have a risk of placental dysfunction? Can the drugs that mum is taking upset the placenta? And then lurking in the background, the silent anti-Rho antibody. Many of the women we see with antiphospholipid antibodies will have an anti-Rho antibody, which tends to cause rheumatological problems in their 50s. And we know with a Rho antibody, we've got a 2% risk of fetal complete heart block and a 10% risk of neonatal lupus. More of that later. Next slide, please. So what do we do in our clinic? Well, we always try and see our women preconceptually and walk them through how we would manage them in pregnancy and give them a letter so that they've got it written down what's going to happen. I think this is really important in women where there's a high risk of morbidity, mortality. And for somebody who's maybe had multiple strokes before, we know they've got high risk of recurrent stroke in pregnancy. Even if we give them heparin, they need to have it written down that they possibly have a risk of recurrent neurological events. So how do we manage them? Well, if a woman's got an antiphospholipid antibody, but never had a problem with APS, we would start them on aspirin alone, 75 milligrams. Some would use 150 these days because the data suggests that 150 might be better, especially in the larger women. If they are undergoing in vitro fertilization, which is really common now, we would add in low molecular weight heparin too, because it's a enormous exercise to undergo IVF, and we want to offer the best we have to offer. We're still not clear whether aspirin on its own or with low molecular weight heparin is the best. And then if they've got recurrent first trimester loss, we would definitely start with aspirin and low molecular weight heparin. Now, in our practice, if they've only had recurrent first trimester loss, we would get them through the first trimester, and our data, which I haven't got time to present, shows that those women will do very well later. So there is something about the antibodies. If you've got some antibody that causes recurrent first trimester loss, it doesn't tend to cause placental dysfunction later. So you can safely stop the low molecular weight heparin after the first trimester. Next slide, please. If we have got, I'm just giving the evidence here for what we're doing. Next slide, please. Now, managing those who've previously had thrombotic problems is a different issue. We really do want to prevent them from having thrombosis in pregnancy. Ideally, if they've had a thrombosis recently, we'd ask them not to get pregnant. But if they do fall pregnant, we would use full dose low molecular weight heparin from early in pregnancy. Otherwise, we split them up to those who've had previous venous events and previous arterial events. And if they've had previous venous events, we'd start them on something like low dose fragmin with 5,000 units daily or more if they are a little larger. And everybody says quite often they are moving from warfarin. Why are you switching over someone who's on full dose warfarin to a low dose of low molecular weight heparin? Well, all we can say is it works. That's what we've done for years, and it's a different anticoagulant, it's a different mechanism of action, and we found that's very effective. And we would double the dose at 16 weeks. By then, the plasma volume has gone up 40%. If they've previously had arterial events, we'd start them on low dose, low molecular weight heparin twice daily from the beginning. And then, of course, there are one or two who have had major problems with thrombosis, and we would start them on higher doses of low molecular weight heparin. Next slide, please. As far as what we would do obstetrically, we would ask the obstetrician to monitor the pregnancy, and we share our care with our obstetricians, guys in St Thomas's. We have a special team and they're very experienced, or we would share care with a local obstetrician. And I think for us, the most important scan would be uterine artery Dopplers at 20 to 24 weeks. Next slide, please. So when we look at the use of scanning, we know that if we do uterine artery Dopplers between 20 and 24 weeks, they're prognostic for later outcome. They are prognostic for placental dysfunction. So if you have bilateral notching or bilateral high resistance, however you want to describe it, we know that the women who are having small babies or preeclampsia fall within that group. Whereas if we have normal uterine artery Dopplers at 20 to 24 weeks, we can all relax, not worry so much about the fetus. New slide, please. And here we have the use of low molecular weight heparin according to weight. Now, at an international level, there has been much criticism, I have to say this, of the use in the UK of increasing doses of low molecular weight heparin for weight, because there is no evidence whatsoever to support it. And if you were to give birth with antiphospholipid syndrome in the US or Canada, they'd use empirical doses. And I think we need to be aware of this, and we need to do some trials to justify using these increased doses according to weight. But this is our practice. It seems to work, and we find very low rates of bleeding with using a weight-adjusted low molecular weight heparin. Next slide, please. And then when women go into labour, we would ask them to stop taking low molecular weight heparin prior to delivery, and they could have an epidural if they hadn't had an injection in the last 12 hours. Next slide, please. And we always remind our women it is safe to use low molecular weight heparin and warfarin if they're breastfeeding. The DOACs, we don't have any data, so we tend not to use them. If a woman chooses not to breastfeed, they can go back to their usual DOAC. Next slide, please. And post delivery would ask them to use contraception, and I think we all know now that we should use progesterone only, pill or implant, and the use of something like Mirena coil is excellent in reducing menorrhagia. Next slide, please. So that's really summarizing our approach, and I think what I'm trying to emphasize is we tailor the use of the drugs we have available according to the phenotype of the woman. So if she's got recurrent first trimester loss, different management from somebody with thrombotic problems. Next slide, please. And then this is some of our recent data which we are about to publish. just showing you that about 10% of our patients have IVF pregnancies. And when we look at the outcome of those pregnancies, they are no different from a natural conception. Next slide, please. And the other thing to say about IVF pregnancies is we have an increasing number of women over 40 who have donor eggs. And you can see at the bottom, 11 out of 69 had donor eggs. This is such modern care, and we have 9 live births and 2 had first trimester losses. So not at all a bad outcome, and fitting in with our data that shows we have about an 80% live birth rate. Next slide, please. So just coming back to recurrent first trimester loss. So we have about an 80% success rate with aspirin and low molecular weight heparin. And a reminder, this is the common area. 80% of recurrent first trimester loss, they never find a cause, but they are keen to find those with antiphospholipid antibodies who account for the rest. And this is a common referral from recurrent miscarriage clinics. The other interesting things about them, they tend to have really itsy bitsy antibodies. And I followed a lot of them up and seen them annually, and many of them lose their antibodies once they get past the menopause, which really needs a bit more further research. And is it that this group are slightly different, or they got something very different going on? Next slide, please. So we have looked at those who don't succeed in having a pregnancy, and if we've got recurrent first trimester loss on aspirin and low molecular weight heparin, we would add in low dose prednisolone, by which we mean 10 milligrams of prednisolone, and we might find a few might respond to that combination. Next slide, please. Could you push it through, Joe? The big question is whether hydroxychloroquine might also make a difference. I'm going to leave Karen to talk all about our HYPATIA trial, which we've battled on with for so many years, despite so many problems. Next slide, please. So lastly, we can have all sorts of other problems with APS in pregnancy. This is a 37-year-old local patient. It's her first pregnancy. She's already had thrombotic APS, and then she develops preeclampsia and then eclampsia at 28 weeks. Well, she has to have a cesarean section because they can't control the eclampsia, and there are some problems. The registrar delivers her during the cesarean section. She becomes shocked, she needs to be ventilated, she's clearly septic, and she has acute renal failure. And her blood pressure requires help. A CT scan shows infarction of the adrenals, splenic wedge infarcts, and bowel infarction. Well, I think for this audience, they must all be aware that the diagnosis here is the dreaded catastrophic APS. So we can have the next slide, please. So catastrophic APS, we have more than 3 organs involved with thrombosis all at one time. This type of presentation is very common. There's infection, there's recent surgery, and despite treatment, there's a really high mortality. This lady, we switched over to argatroban, and we plasma exchanged her. She got intravenous gamma globulin, and she did recover, and she's now on adrenal support, but I'm back on warfarin, and the baby was fine. I think the other thing to say is there's some controversy around steroids in catastrophic APS, and perhaps we can discuss that later. Certainly the McMaster guidance would say not to use them, and I would favour that, and I suspect Karen might say, no, I'd like to use them. So there is no agreement because there's no evidence. Next slide, please. So here we go. I just want to remind you, if you've got a woman with antiphospholipid antibodies, please check Furrow antibodies, because they're just wicked. They've got a 2% chance of complete heart block in each woman. You can do fetal cardiology monitoring of the heart. If you haven't got complete heart block by 30 weeks, you won't get it. And the other thing is neonatal lupus. Now, this has caught out our local dermatologists several times. And this is a baby who's got neonatal lupus. And you can see it's got periorbital erythema. If you're in the States, you call it raccoon eyes. If you are here in the UK, you call it owl eyes. And the babies are covered. You can see this poor baby's got a rash on its extensor areas. These babies tend to be a bit miserable. They cry all the time, and I expect they're feeling really itchy. And all of this effect will wear off as they grow older. Next slide, please. So this is my last slide. I think obstetric APS is a fascinating area. You never know what's going to happen. And we've got this problem about the antibodies having different effects in different women. We haven't got a handle on how we can say a woman's pregnancy is going to go unless we've got a past obstetric history. If you've got a past obstetric history and she had preeclampsia at 24 weeks, you know they're going to have preeclampsia at 24 weeks again unless you do something. Worse outcomes with those who've had a previous history of thrombotic APS, and we are tailoring the regimes for the different phenotypes. And I think at the moment, the 80% live birth rate is pretty good, but I'm hoping Karen will tell us that the HYPATIA trial will give us many other options. So thank you for listening. And I am now going to hand over to Dr. Karen Schreiber, who is a consultant rheumatologist at the Institute for Health Research in Denmark now at Odense University. She had a long and illustrious time with us at Guy's and St. Thomas's. She and I started the HYPATIA trial, but it has been an absolute nightmare to deliver. We've been affected by all sorts of unexpected problems, such as Brexit, the changes in the system that we have in the UK for delivering research. And Karen has now taken the trial over to Denmark. I'm going to stop talking now. Karen, how lovely to see you. Thank you very much for talking about HYPATIA.
Thank you, Beverley. That was very kind. And thanks for letting me present here. I'm very delighted to give you an update on the HYPATIA study. So I will use 10 minutes of the next hour to talk about HYPATIA. What is HYPATIA, and where are we now? Where have we been, and where we're going to head? Hopefully, we're going to complete the trial. And at the end, if you feel tempted to participate, please do get in touch. This is something we would be really delighted about. Beverley has been through antiphospholipid syndrome in very detail. That was wonderful. And Beverley is very fascinated by the syndrome, and so am I. And really, I've dedicated a lot of my career to improve the pregnancy care that we're giving these women. And as Beverley mentioned, we're treating women currently with aspirin. Some women also receive heparin, but really we ought to know whether we can do better, whether we can improve pregnancy outcomes. And the question we want to answer, we would love to answer, is whether the antimalarial hydroxychloroquine, Plaquenil, improves pregnancy outcomes in these women. This is why back in 2014, we sat down, we wrote the first draft of the protocol and designed the study to answer that very question. So this is a graphic abstract. So if you start on the very left-hand side, it's a double-blind placebo-controlled trial. And what we do is we randomize women who are planning pregnancy, so women who are not yet pregnant, who have persistent antiphospholipid antibodies. We randomize these to either hydroxychloroquine 200 milligrams, that's the low dose, or to an identical looking placebo. We aim to randomize 400 women to achieve a sample size of 328 women. And we're looking at a composite of antiphospholipid antibody-related pregnancy outcomes. So really, we want to know, does the addition of hydroxychloroquine improve pregnancy outcomes? We will also be doing sub-studies. We will be looking at hydroxychloroquine levels and different other sub-studies as well. So whom do we include? We include women with persistent antiphospholipid antibodies, and Beverley mentioned that a few times. So we look for women who've got a persistent subtype of antibodies. And these women, if they do and they are planning pregnancy, they would actually be eligible to be entered into the study. We do exclude women who are already pregnant, who have any allergies to hydroxychloroquine, of course, and who are already treated with hydroxychloroquine. And you can see there's a list of further antibodies here. And actually, I would just like to highlight women who have anti-Ro antibodies. That were the women who have a risk of the babies developing congenital heart block and neonatal lupus. These women are usually treated with hydroxychloroquine anyway, so they would not be eligible for this study. And also, women who've had a previous pregnancy failure on hydroxychloroquine are also not eligible for the study. What we're looking at is a composite endpoint, as I mentioned. So that's that's our primary endpoint, and this includes first trimester, second trimester, third trimester loss, or complications associated with placental dysfunction. And we will also be collecting numerous secondary endpoints, such as the gestational age at delivery, and of course the baby weight, because this is something we're interested in, and that's of interest for how the baby will do afterwards. So this I always laugh when I look at this map, because Canada is very, very big. We have one center who hopefully will be able to join us. That's in Calgary. That's Dr. Leslie Skeeth, who will be joining the team hopefully soon. You can see here the UK is highlighted, and we have 8 centers and several other interested centers who are currently participating. Then we have Denmark, teeny weeny country here, and Italy, who also will be joining. And here's an overview just for you to see which centers we have in the UK. The ones that are in bold are currently open for recruitment. And St. Thomas's, needless to say, is the largest and biggest center. Andy Doyle is one of our best recruiting soldiers on the ground, alongside Johanna Young, who's the specialist nurse in the unit. Then we have Cambridge, we have Oxford as well. They are doing really well, and we're so delighted to have them. Royal Free and UCLH are struggling a little bit, but we hope that we really can get these centers going. They have green light for recruitment, albeit I should say that the recruitment is paused at the moment in everywhere, because we're doing a little bit of a sponsor change. And hopefully in the future, we will be able to open up in Liverpool and in Manchester. In Denmark, we have several sites. We're a very small country, so we will do our very best to open every unit we have in the country. The advantage we have is we know each other very well. So we have PIs who are very close friends and who feel that they would go very far to help the trial. And we have our center in Turin. This is Professor Savino Shasha. We have our center in Dublin who will be opening. That's Finola Niainle and her team. And as I mentioned, it's in Calgary, Leslie Skeeth, who will be joining. I also indicated we have a sample size, which is pretty ambitious, but really is what we need to show that there is a benefit or not. We're aiming, as I mentioned, to recruit 328 pregnant women. We have currently enrolled 35. So we are struggling a little bit behind, but we will hopefully get there. The trial is very easy to conduct. It's a low maintenance trial, as I always jokingly say. So we do include women before they are pregnant. We randomize them, if they are eligible, to either hydroxychloroquine or a placebo. And we would see them every 3 months, which is standard of care. and every 3 months during their pregnancy, again as standard of care. And we would see them once postpartum, ideally within 6 weeks. Where are we now? So you can, as I already mentioned, it has been a long way. We started back in 2015 when we received NIHR funding, and you can see the timeline is long, and we've met many obstacles underway. But I also want to say we're not willing to give up at all. We managed in March 2022 to raise an additional 1.3 million euros. And this will hopefully allow us to complete the study by 2027. So we're going, and we will continue, and we will hopefully complete the study. Right now, we are paused in the UK and in Denmark. It's because we had to change the sponsor. And I say that in one sentence, but I promise you it's a long bureaucratic exercise to actually complete. It took us so far, I think 8 to 8 months we started this. So it's a long thing to do, but it's not impossible, and we are good. We actually have approval in Denmark. We have also approval for a sponsor change in the UK, and now we just need to reopen our British sites and the same for the Danish sites, and then hopefully we can continue our work. You may also know that now in the EU, we have a new system, which is called CETIS. We have received CETIS feedback last week, and they only had minor corrections for our application. And we fed back yesterday, addressing all their small little items, and hopefully we will get CETIS approval very soon. If you feel tempted to help and you're interested to participate, do get in touch with either Beverley or myself. We would be delighted to have you on board. And I think this is where we are. Thank you.
Great. Thank you very much, Karen. That was a really great overview. And yes, everyone, please take note of the email addresses, and we'd really appreciate any contacts or potential patients to be referred, even if you think they're potentially not applicable in terms of recruitment criteria, but it would be really helpful. Okay, so with that, I am now going to hand over to another Guy's and St Thomas's colleague, Dr Andrew Doyle, who I work closely with in the Hemostasis and Thrombosis department at St Thomas's. Andy is a consultant hematologist, and he provides both clinical and laboratory care with us at St Thomas's. He has an interest in thrombosis and hemostasis like ourselves, and part of our multidisciplinary team looking after patients with APS. So he is going to talk to you now about thrombotic APS management. Over to you, Andy.
Thank you. Thank you. I've been invited to talk to you about thrombotic antiphospholipid syndrome and the management of where we're up to in 2023. So what I'd like to go through today is the clinical features of thrombotic APS, how we make the diagnosis, some of the areas where we're getting to understand the disease better in terms of pathophysiology, the roadmap of treatment and where we're at in deciding treatments up until this day, and then looking at the prognosis and how we counsel our patients of what to expect in the longer term. So looking at the clinical features of thrombotic APS, it's a rare condition. If we look at the incidence, it occurs in 1 to 100 per thousand per year, with a higher prevalence of about 40 to 50 per thousand per year. If we look at when this occurs, in women it happens at a younger age, in men it happens slightly older. And I'll discuss this in a little bit more detail in a few slides' time. We see that about 9% of patients will have another associated autoimmune disease, with the most common ones being a systemic lupus erythematosus, and there's by far a female predominance. If we then compare the prevalence as an instance, as I previously described, to actually the prevalence of antiphospholipid antibodies in the healthy population, we can see that a lot of people will have anti-cardiolipin, anti-beta-2 glycoprotein antibodies. So we recognize that although these antibodies are prevalent, they don't always associate to having the condition, the disease. We also see that these antibodies are present transiently with bacterial and viral infections and malignancy, and obviously the clear association with anticardiolipins and syphilis has been previously described. And therefore, it's key that we show persistence of these antibodies in making the diagnosis as opposed to a one-off testing. So as we alluded to on previous presentations, this is the thrombophilia that's associated with thrombosis in all vascular beds. So arteries, veins, and the microvasculature, thrombotic microangiopathy. We see that the antibodies have a predilection for causing stroke and TIA, which we'll discuss in more detail in the next, but also can affect various other parts of the body. In terms of venous thromboembolism, DVT and pulmonary embolisms are common. And we also see that people get blood clots in the microvasculature, which we do recognise in catastrophic APS, which is a rare complication occurring in 1% of people having antiphospholipid syndrome. And as we've mentioned earlier, that microvascular thrombi can occur in the placenta. If we look at venous thromboembolism, we do see that antiphospholipid present in about 10% of those with unprovoked VTE. And in young patients having stroke, they're present in 15 to 20% of patients. However, if we're looking at young patients having myocardial infarctions, the level of detection is much lower at 1 to 5%. So Karen showed this slide earlier, but I'd just like to discuss it in more detail. So we see the most common sites of thrombosis, stroke, DVT, and pulmonary embolism. But if patients have clots at unusual sites, and these include splanchnic vein thromboses, retinal vein occlusions or retinal artery occlusions, and also have unexplained digital gangrene or leg ulcers, we should consider testing them for antiphospholipid syndrome as well as being rare complications. This was a cluster group analysis based upon the European registry data, and it divided the antiphospholipid cohort into 3 main groups. One was an older cohort, having predominant male cohort, having mainly arterial disease, livedo reticularis, and having cardiovascular and cerebral vascular disease. In group 2, there was a female cohort who had an autoimmune phenotype with lupus and also venous thromboembolism, with their antiphospholipid testing showing a lupus anticoagulant. In group 3, this was a female cohort with no other autoimmune disease, but had preponderance to triple positivity and VTE. And as Beverley and Karen have kind of always mentioned to me, that everyone has their own condition. So although these 3 groups are useful, everyone has their own disease and disease course. We then consider the kind of non-criteria manifestations, which may not necessarily be thrombotic, but there are other kind of things that may point to a diagnosis of antiphospholipid syndrome or may need investigating under their own merits. And these include valvular disease due to immune deposition on the valve, migraines, cognitive dysfunction, epilepsy, and chorea. We see that livedo reticularis, particularly with cerebral disease indicating Sneddon's syndrome, and leg ulceration. We associate antiphospholipid syndrome with thrombocytopenia, but rarely that this is a severe thrombocytopenia that excludes the use of anticoagulation. We see that patients get renal disease, and under microscopy, we see that there is a proliferation of the endothelium causing a vasculopathy, as well as in some cases microvascular thrombosis. And we also associate having the antibodies with accelerated stenosis and fibrosis of organs and vessels. So how do we make the diagnosis? And I'm sure you're all aware of the Sydney criteria, which followed on from the Sapporo classification of the APS. And this is nearly 20 years old now. So the thrombosis events, patients have to have 1 thrombotic event, and in any of the vascular beds that I discussed earlier. And the laboratory parameters, which again, I'm sure you're all aware of, are a lupus anticoagulant, ideally by a DRVBT and another test, an IgG or an IgM of an anticardiolipin or anti-beta-2 glycoprotein antibody, and that we recommend testing is repeated after 3 months to show persistence of antibodies. So what causes APS to happen? So to break this down, we get antibodies forming against phospholipids, phospholipid binding proteins. And of course, we have our phospholipid membranes are ubiquitous on our cell membrane as part of our cell structure. This then causes a prothrombotic state, and we recognize that netosis, increased tissue factor release, and platelet activation may all play a part in this. And we also recognize that the endothelium becomes activated and can proliferate, leading to this combination of thrombosis and vasculopathy. The key protein that is thought to cause this condition is the beta-2 glycoprotein, and an antibody forming to this, which is part of our diagnostic criteria. So the antiphospholipid, so beta-2 glycoprotein normally occurs in a ring-like structure, and usually upon oxidative stress changes to this fishhook structure, of which a cryptic epitope is becomes available for to which the antibody can then bind to, and this can bind to various proteins on the cell surface, including toll-like receptors, annexin, and LRP8. This then causes various cells to become activated, and these include monocytes, neutrophils, platelets, and the endothelium, causing this prothrombotic state to happen, and with a second hit of complement activation and coagulation. This is thrombin generation curve, which I'll just discuss briefly. So this shows the amount of thrombin, which is our key mediator of the coagulation cascade. It's a negatively skewed normogram in its normal appearance, and we measure several things to give an indication of how much thrombin is being produced, including its peak height and the area under curve, which we refer to as the endogenous thrombin potential. And we can see in vitro, so in the laboratory, that according to what the serology the patient has various degrees of attenuation of this thrombin generation potential. And this is recent data from the Italian group. This data, which has been alluded to previously by Beverley, somewhere from my colleague Karen, showing that complement is activated in all cohorts of patients with antiphospholipid syndrome, and those who haven't had any disease markers such as obstetric morbidity or thrombosis. So we can see that these patients have a primed complement system. We're increasingly recognizing that complement is a key mediator between the innate immune system and the coagulation cascade, and we can see that various markers of coagulation, of complement activation, cause upregulation of neutrophils and monocytes. I think we're beginning to understand that netosis is a key part in development of antiphospholipid syndrome, and there's certainly some good work coming from Ann Arbor, and I also recommend this review article, which has been published recently in JTH. So we see that the antibodies bind to toll-like receptors on the surfaces of neutrophils. They become activated by various intracellular pathways, and then go through a process of netosis, which is the release of neutrophil extracellular traps. These are basically a lattice work of the DNA and histones, which are extruded from the neutrophil as a process of cell death. And these cells and this network, I kind of think is similar to a trawler, and basically acts as a scaffold for coagulation proteins to bind to, and also traps in cells that can mediate thrombus formation. We then move on to the treatment of thrombotic APS. So this is work from nearly 30 years ago from our centre, and we can see that patients who aren't anticoagulated versus those who are anticoagulated with a vitamin K antagonist have a significantly different outcome, with recurrence being recognised as being early and recurrent. And this is a EULA guidance published about 4 years ago, and shows that vitamin K antagonists remain the standard of care for treatment of thrombotic APS. In those who have an unprovoked first VTE, we recommend vitamin K antagonists with a target of 2 to 3. And certainly we avoid in those who have triple positivity, so those who have all 3 diagnostic tests that are positive, not to have a DOAC. For those who have provoked VTE, we generally avoid testing for antiphospholipid markers and would be guided upon the nature of their thrombosis. With recurrent VTE, we push up their INR target. And those who have recurrent arterial thrombosis, I think this is a grey area, and the recommendations is that INR target can be 2 to 3 or 3 to 4, with the consideration of low dose aspirin. And certainly with recurrent arterial thrombosis, we would increase up their INR target, consider whether there should be the addition of an antiplatelet, or consider switching to an alternative agent, low molecular weight heparin, or which we may use in our centre is fondaparinux. If those who don't have thrombosis, we consider use of low dose aspirin, which I'll discuss in a few slides' time. So what intensity of anticoagulation should we use in thrombotic APS? And there's been 2 randomized studies. One was the Crowther study based in the US, and the other was the WAP study. And both showed non-significance between the 2 INR targets in looking at thrombotic recurrence. And the WAP study did a kind of small-scale meta-analysis looking at the 2 studies and showing that the main statistically significant difference was at the bottom for an increased risk of minor bleeding with a higher INR target, and the x-axis is showing the odds ratio for those on a higher INR target. Now, I think we also need to understand that potentially patients with venous clots and arterial clots may require different INR targets, and I think this is something that we need to further evaluate, and which wasn't demonstrated in this study. So then we moved on forward a few years, and with the advent of the DOACs being widely used in unprovoked VTE and in its long-term treatment, there was then to consider, can we use this in patients with APS who have this very prothrombotic tendency? So the first study was UK-led, and it was comparing warfarin to rivaroxaban, and was the RAP study. So the study randomized patients to warfarin or rivaroxaban for 42 days and used a laboratory endpoint of the thrombin generation, which I alluded to a few slides ago. So we can see with the thrombin generation, so this is the normal control in blue, and the median is this one highlighted in purple, which is buried in between the red and the green. So we can see that the shapes of the curves are slightly different, and I'd like to highlight that the endogenous thrombin potential, so the area under the curve, was larger for rivaroxaban than warfarin. But in the study, there was also, for the secondary outcome, there was no increased signal of adverse events clinically. So then we move on to the first clinical endpoint study, which was TRAPS. And this was a multi-center study in Italy looking at warfarin versus rivaroxaban in patients with triple positive APS. And we associate this as being the high risk group. This study was terminated early, and the reason for this was an excess of thrombosis and bleeding events in patients on rivaroxaban. So we can see on the Kaplan-Meier curve that there was an early separation of these compounded endpoints for patients on rivaroxaban. And this was looking over a period of 1.5 years. So similar studies were then performed. So the Spanish study led by Audi Ross et al. Published a year or so later. This looked at a slightly larger cohort of patients with thrombosis in terms of it included all types of serology and included arterial and venous events. And although it wasn't a trend to statistical significance overall, this study recognized, similar to the TRAP study, that there was a higher risk of recurrence in thrombotic, in triple positive APS and those with arterial disease. So we're starting to, as clinicians, in the latter part of the 2010s, we're recognizing that certainly triple positive and arterial shouldn't be receiving DOACs. And then later to publish was the Astro APS, which used apixaban versus warfarin. And we can see that the study had to have various protocol changes in light of the 2 previous studies, and therefore was rather some heterogeneity in the follow-up of the data. But again, this gave a signal that with apixaban, there was an increased rate of thrombosis recurrence in patients on apixaban in the longer term. So then moving on to those with persistent antiphospholipid antibodies without thrombosis. And I think this is a question of that it still remains with some grey area. So we see that from follow-up data of patients, we see that there's a development of thrombosis of 1.8% per patient year. And this certainly isn't what we see in patients who've had previous thrombotic events. And we recognise that this is a much larger cohort than patients who have antiphospholipid syndrome. Risk factors are those who have lupus anticoagulant, those who've had preceding arterial disease, triple positivity, or have hypertension. We've described that aspirin has reduced the risk of first thrombosis with an odds ratio of 0.5. And this predominantly had an effect in those who had lupus, obstetric APS, and also some descriptions have been in those who also have concurrent atherosclerotic risk factors. We must also bear in mind that there is a major bleeding risk with aspirin, which is 0.3% per patient year. So I think we also need to consider, do we give a patient who's relatively healthy with an incidental low titer anticardiolipin? Do these patients warrant giving aspirin, as opposed to those who have numerous cardiovascular risk factors, who are older and may also have triple positivity? So we just do need to consider that as clinicians. Then moving on to the prognosis of patients. So you have a patient who's had 1 thrombosis. What do we advise them in terms of their long-term risk in the future? So the European Antiphospholipid Registry looked at patients from 1999 to 2009 with a cohort of 1,000 and showed that there was a thrombosis recurrence risk of 15% at 5 years. And these were similar to the first events that we were seeing of predominantly stroke, TIA, and VTE events. They also recognised that there was high rates of smoking, hypertension, and dyslipidemia in this cohort. And mortality rates were 9% over the 10-year period, with the most common cause of death being thrombosis. So I think it's key that when we see these patients that we reiterate that anticoagulation control and modification of cardiovascular risk factors in key in preventing death and recurrent thrombotic events. So we've got a cohort of patients who have an increased risk of thrombosis. How do we begin to identify who these patients are going to be? And is there any scoring system? So the first one and the most widely described is the GAPS score, which was first described about 10 years ago. And it's using various risk factors, including atherosclerotic risk factors and the patient's antiphospholipid testing results. And to validate this, they did a developmental cohort which showed that patients with a high GAPS score had a high risk of thrombosis in comparing to those who didn't. And this was shown in their validation cohort as well. I'd just like to point out that this uses the antiphosphatidylserine and prothrombin test, which isn't recommended by the Sydney criteria and ISTH at present. And therefore this was reflected in the adjusted GAP score, which was then published subsequently. And it also doesn't give an indication of what test ELISA levels are significant in these patients. A recent study from Israel looking at recurrence patterns showed that, which we recognise in our centre, is that the preceding site of thrombosis also predicts the site of recurrence. So if you've had an arterial event in the past, you're more likely to get an arterial event in the future, and similarly with venous thromboembolism, with only 6% of patients having a mixed picture of arterial and venous disease. They showed that venous thrombosis was had a higher recurrence rate, and that in the arterial recurrence, that hypertension and high titer antibodies were more common, and that those who had venous recurrence, a higher GAP score, a younger age in comparison to the arterial disease, male patients, and an IgG isotype had risk of venous recurrence, and that this recurrence risk persisted over time. So we need to be aware that and counsel patients that their risk of having further clots isn't just in the first few years, it can happen throughout their life. So this is an algorithm from our colleagues over the other side of the river in UCLH. And the top part of the diagram reflects a Euler guidance of either using vitamin K antagonists for venous disease with a target of 2 to 3, and arterial disease of using 2 to 3 or 3 to 4. What I'd like to highlight is what do we do in those patients who have recurrent thromboses? As we discussed earlier, we could increase their INR target to 3 to 4, or consider switching the patients to higher doses of low molecular weight heparin. Or in some patients, which we use in our centre, we can consider switching to fondaparinux, and we hope to, and we're presenting our data at ISTH this year on that. There then also remains this kind of bag of alternative treatments that we can consider. Do we consider adding in an antiplatelet, hydroxychloroquine, statins, or vitamin D? Or do we consider immunotherapy such as rituximab? And I think this certainly remains a grey area of what we do. And I think this is something that we need to work towards as an APS treating community, of how we then treat patients who have recurrent thrombosis despite standard of care. So to summarise, thrombotic APS is a heterogeneous disease. We're increasingly recognising the role of the innate immune system in development of thrombosis in APS, and potentially this could be a target for disease treatment in the future. At present, warfarin remains the standard of care, and this is particularly in arterial disease and those with triple positivity. And I highlight that the treatment of cardiovascular risk factors should not be ignored in this cohort. The recognition of we should recognise there are different disease patterns that require long-term follow-up, and that thrombosis recurrence remains an unmet need. Thank you very much.
I'm going to hand you through the many permutations of cerebral APS. Thank you both.
Great, thank you for the introduction, Beverley. Sorry, my connection has just gone a little bit wonky, so I'm hoping you can all hear me okay. Okay, so I am just going to share my screen. And okay, just hoping I can just talk you through. Okay, so of course we've already gone through all of the discussion around what antiphospholipid syndrome is so far, so I'm not going to kind of repeat that, but suffice to say that for patients who present with cerebral, what we would describe as potential cerebral manifestations, and I think I use the word potential because at best a lot of these presentations can be really difficult. I think often for those of you who are used to managing patients who come to clinic with very non-specific symptoms, it can often be really tricky to determine whether or not they are true manifestations of antiphospholipid syndrome or not. And Andy has just shown a previous diagram looking at criteria versus non-criteria manifestations, and just drawing your attention here to the CNS neurological manifestations. I think, as he has discussed earlier, patients, while some can present with overt stroke-like symptoms, and clearly that's a little more obvious and more easily defined, you have lots of patients who can often come with symptoms such as really severe migraines, recurrent issues of chorea, for example, patients who have TIA-like symptoms, and often it can be really difficult to define what exactly is a presentation of cerebral, what we determine as cerebral complications of APS. And hopefully my colleague, Dr. Sommerville, will take you through some of those presentations in a little while. But just to bring you to a case then of a typical patient who can present to our clinic. So this is a patient she's a 28-year-old female and presented with abnormal limb movement. So her symptoms started approximately 6 months ago with no known precipitating cause, so they were just completely spontaneous. She was seen by a neurologist who diagnosed chorea, and there was no known family history of any neurological disease, and she had gene testing for sort of inherited causes of chorea that was negative. She had further investigations, including an MRI brain scan, and this showed only 4 white matter hyperintensities, and she went on to have a lumbar puncture and CSF fluid analysis was normal. But interestingly, her antiphospholipid antibody screen, which was done to assess these white matter hyperintensities in a young female, showed her to be significantly positive for IgG and IgM anticardiolipin antibodies and beta-2 glycoprotein 1 antibodies of greater than 100. So I'm going to leave that case there just to have you to all have a little think about what you might do. And then just another case of a 47-year-old gentleman who has had a recent diagnosis of stroke, so quite a clear-cut stroke, no known cardiovascular risk factors, and he's been referred to discuss treatment options because he has a persistent antiphospholipid antibody, but a single positive anticardiolipin of around about 31 with this repeat level showing approximately 37. So at best it's sort of marginally positive low titer antiphospholipid antibody. So I'm just going to leave those 2 cases there for you to ponder, and I'm going to hand over to my colleague Pete, who will talk to you a little bit more in detail about the sort of manifestations and presentations of cerebral APS. Over to you, Pete.
Hello everyone. This meeting is being re-recorded owing to some terrible AV digital issues that affected the live conference. So I was going to talk to you about cerebral antiphospholipid syndrome. I'm a consultant stroke physician at St Thomas's, and I work really closely with the haematologists here to provide multidisciplinary care for antiphospholipid cases. And of course, quite a few of them have got stroke or TIA or questions about those in their history. And we believe that the MDT approach is the one to do. So I just wanted to make a few explanatory comments about all of this. Stroke, TIA, and antiphospholipid antibodies coexist. And I think it's important to say that and to state why we think there's a association. 20% of patients with antiphospholipid syndrome suffer stroke over 10 years. And actually, if we look at the younger population of stroke and TIA survivors, 17% will have antiphospholipid antibodies and 12% of TIA cases will have antiphospholipid antibodies, which is much higher than the population rates of about 1 to 5%. A study on stroke with antiphospholipid antibodies showed that the mean age was 46 years. And a systematic review of 43 studies showed that the presence of antibodies under the age of 50 increased the risk of having a stroke by over 5 times. We see a lot of brain disease, I think, in these patients. One case series of 110 patients with the antibodies, unselected otherwise, showed a variety of cerebrovascular manifestations, including 22% of whom having had large infarcts, 17% with hyperintense white matter foci, of which more later, and 10% with little infarcts. So I wanted to say where we're coming from in the stroke world. There is a national guideline which has just been released or re-released in the spring of this year, which is an update from the last one from 2015. Actually, the antiphospholipid recommendations haven't changed, and that is to say that so we're basically testing patients who've had a stroke or TIA under the age of 50 for antiphospholipid syndrome, and that's linked to the evidence I showed you earlier, where you find this high prevalence in the under 50s. there is still much research to do, I think it's fair to say, to get the exact screening criteria that would be most beneficial. So we screen the under 50s, we screen people with a history of autoimmune rheumatic disease, especially lupus, those with a history of thromboses, venous thromboses, and of course those with a history of pregnancy loss or major pregnancy problems that are recurrent. However, if we do find antiphospholipid syndrome, we manage them hyperacutely in the same way as people without. So that is to say, they are still eligible for thrombolysis, for thrombectomy, two of the treatments that we use, which are rapid reperfusion therapies, and antiplatelets, of course. But the long-term secondary prevention decisions need to be made on a multidisciplinary basis. I wanted to say exactly what we mean by stroke and TIA, because I've noticed that the words get used in meaning a variety of different things. What I want to mean by stroke, what I think we should mean by stroke, is it's a clinical syndrome. So this is not a radiological appearance. If there's if I see that someone's got an infarct in the brain, I don't automatically tell them you've had a stroke, which can be quite concerning news if it was asymptomatic, which quite often they are. So a stroke is a clinical syndrome caused by a focal neurological deficit from a vascular cause. And of course, there can be ischemic stroke, which is what we're talking about here, but a sixth, hemorrhagic as well, which I won't talk about today. A TIA is the same definition, but the symptoms get better in under 24 hours. Note that these are clinical and not radiological definitions, as I've said. I wanted to say what sounds to us like a TIA, because obviously in the world of antiphospholipid, you're likely to come across migraines, and it's useful to be able to tell them apart. A TIA, really what we want to hear are 4 cardinal features. They don't have to have all 4, but the more they have, the more likely it is, I think, that it is a TIA. The first being acute onset, like really acute. One moment you're completely normal, and then the next moment you have a focal neurological deficit. This can't come on over 10 minutes, you know. And the symptoms are worse at the beginning and they wear off. So we don't like to hear too much about kind of escalating symptoms. Well, it's fine to hear about them, but we don't like to call them TIA. They need to be focal. So, you know, weakness on one side is a good focal symptom. Loss of vision in one eye or in one hemifield is a good focal symptom. Loss of consciousness is not. And in general, it's more suggestive that things are TIA if symptoms are negative. So that is to say, a loss of sensation, numbness, loss of power, weakness, loss of sight, darkening of vision, blackout of vision, rather than the positive equivalents, which would be tingling, added movements, flashing lights. So the disease spectrum of ischemic cerebrovascular disease, really the 3 main disease entities represented by these images. There are others too, but this is one of the MRI sequence called diffusion weighted imaging, DWI, in which acute infarcts, as in the last 2 weeks, show up bright white. And you see here, this is a classic cortical infarct, reasonably large in the left parietal lobe. These entities, which are in the deep white matter, here dark on a CT scan, are often referred to as lacunar infarcts. We have this slightly arbitrary 1.5 centimeter maximum size for a lacunar infarct, which is that this is right at the top of it. I think you could just about still call this a lacunar infarct. And in contrast to the large cortical infarct, which tends to be due to a large vessel occlusion, these tend to be the small perforating vessels supplying the deep white matter structures. And so we tend to think of this more as a consequence of atherosclerosis, though not necessarily. This could be atherosclerosis, or it could be other causes, including embolic causes. These are white matter hyperintensities. You see them. The more brain scans you do, the more you see. You tend to see them more in people with vascular risk factors. They tend to be deep. That one's not that deep, but the rest are here, and small. And they don't tend, and they tend to be chronic. And so, you know, if you look at the DWI pictures, which are these, you wouldn't see them lighting up bright unless they were acute infarcts. So what counts as cerebral antiphospholipid syndrome? I mean, we've used the term a few times, I think, and you know, in one reading, it's quite simple. You know, you've got the antiphospholipid antibodies, you've had a thrombosis, therefore you've got antiphospholipid syndrome, and if the thrombosis is in the brain, you've got cerebral antiphospholipid syndrome, and that's fine when it's a clear-cut case. But of course, it's not always clear-cut to say that somebody has a thrombosis in the brain is one thing. Sometimes, you know, some of these white matter hyperintensities, you don't always completely automatically say this is thrombotic disease. I'll go on to talk about that. And also the spirit of diagnosing antiphospholipid syndrome is, I think, to say that the antiphospholipid antibodies have had something to do with the cause of the thrombosis. What about if you see a thrombosis in the brain and it's completely fully explained, or perhaps even over-explained by all the vascular risk factors they have already? How do we think about the etiological role of the antiphospholipid antibodies then? It's an open question. What about asymptomatic cerebrovascular disease? Is that the same? What about migraine? The APS people do have more migraines. Does that count? So, you know, some questions here, and I'll come on to them. This slide is to make 2 points, really, one practical and one philosophical. I'll make them at the end. This is a case of a 33-year-old man who came to my clinic recently, who awoke with jumbled speech and headache and had these symptoms for 2 days before they got better. So, you know, that's a length of time that puts him in a, if this was a stroke, it's a stroke rather than TIA territory. He had a past medical history that included obstructive sleep apnea, although he hadn't been on CPAP, hypertension and obesity. And although his investigation, his blood work initially was relatively normal, his LDL was raised at 2.1. His blood pressure was in the hypertensive range. He had a CT scan, which I think you can probably appreciate here, if it's coming through okay, that there is an infarct in the deep white matter. It's slightly larger than the 1.5 centimeters, probably in a part of the brain called the corona radiata. And I think that this was questioned immediately as in whether it was an infarct, but our local radiologist felt that it probably was. He had normal cardiovascular work. We often will do a period of cardiac monitoring, and in a young patient, a bubble echo to exclude a patent foramen ovale. These are patients with an unexplained stroke with other vascular risk with no other vascular risk factors who have a PFO will often offer closure of the PFO as an interventional procedure. His carotid ultrasound was normal, carotid disease being an important stroke risk factor, but his antibodies were very markedly abnormal, as I think you can see there, in a triply abnormal way. So in terms of his management, he had a statin added to manage the hyperlipidemia, an antihypertensive for the blood pressure. He was referred to sleep clinic for the commencement of CPAP. OSA is definitely a stroke risk factor. And he was referred to our dietitian for his obesity. And we discussed him at our antiphospholipid MDT, and we decided, slightly unusually, given that he hadn't had repeat serology, we normally wait for the repeat serology, but in his case, because some of the antibody titers were so high, that we'd start him on warfarin straight away. So the 2 points I wanted to make about this, the straightforward point is that actually people are getting more complex. More and more coexistent disease, I think, is seen. I mean, you know, just take the example of diabetes. The rates of diabetes are going up, rates of obesity are going up. And so more and more, I think we're seeing cases of antiphospholipid syndrome in conjunction with other vascular risk factors. And the practical point is, don't make sure the other vascular risk factors are being looked at. In his case, there was at least 5 interventions that needed to take place to manage his vascular risk, only one of which was direct management of his antiphospholipid. And the philosophical point is one that I've alluded to, which is that this infarct is almost over-explained by his risk factors. It would be of no surprise whatsoever that such a man with such a background should have a stroke, even if he had completely normal antiphospholipid antibodies. So the fact that they're raised, do we say that he's got cerebral antiphospholipid syndrome? Could these not just be incidental antibodies? What I want to suggest is that that question is maybe slightly unanswerable in a way. All we can do is observe associations. And the research that we have shows the association between the antibodies and the stroke, shows the benefits of some treatments. And I think we should just probably treat the presence of antibodies as a risk factor like any other. So if we say cerebral APS, we're not really even suggesting that the antibodies have to have caused the disease. All we're saying is that we've spotted the disease and we spotted the risk factor in the form of the antibodies, and it gives us a target to manage. And in this case, that was with warfarin. Now, I said I'd talk about white matter hyperintensities. Quite a lot of our cases that we do discuss in antiphospholipid MDT concern patients who perhaps don't have a clear history of stroke, but for whatever reason, like in one of Karen's talks earlier, have had a brain scan that shows perhaps some white matter hyperintensities. Now, do we say these are caused by thrombosis? Do we say these are caused by normal aging? What do we say? Well, there's the age-related white matter cerebrovascular disease scale that has a number of different stages. You can count the white matter lesions. You can see here scale 0, 1, 2, and 3. 3, if we saw it, would be quite extensive. And the basal ganglia lesions, these are the basal ganglia, lower part of the brain, and you can count these little sort of infarcts greater than 5 millimeters. The cause of this white matter change is often thought to lie somewhere between atherosclerotic and arteriosclerosis and lipohyalinosis. So what we're talking really here about is vessel dysfunction. These are the smallest vessels having dysfunction. And actually the role of thrombosis is unclear. I mean, it's almost certainly the case that it has some role to play, but progressive narrowing until occlusion of vessel walls might be part of the story as well. And we see this much more in people with vascular risk factors. And there's a huge literature on this that I don't have time to present. But I just wanted to make a general point here, which is that the prevalence of these sort of cerebral small vessel disease markers, of which white matter hyperintensities are important ones, is high and rises with age. So, you know, we might be talking about, if we're testing people for antiphospholipid, perhaps this group 40 to 45, 46 to 50, 51 to 55, the first 3 sections of this graph perhaps. And we see that the red bars representing white matter hyperintensities are actually seen in the majority of people. So some are seen in the majority of people, and you know, it would be rare to find a 60, 70-year-old without any. The lacunar infarcts, which we think is perhaps a more thrombotic phenomenon, are still seen in some cases as part of a normal kind of range of people. We'll ignore enlarged perivascular spaces, cerebral microbleeds, and brain atrophy for now, although there's probably interesting things to say about them as well. So how do you tell? I mean, one of the, you know, there's a rule of thumb. You're allowed to have as many white matter hyperintensities as decades you've lived, which is fair enough. All I'd say is that there isn't an exact way of subdividing these and saying, look, this is over the amount that you might expect with the vascular risk factor profile. The way that we do it is we tend to discuss them in some detail in our meetings, and you know, we I, from a stroke point of view, our neuroradiology colleagues and of course hematology colleagues come to a decision about, does this seem to be excessively thrombotic looking brain appearances? And then we can use that to kind of help inform our decisions. So there's a lot of nuance here. I think it's important to talk about migraine. Migraine does come up quite a lot. 20% of people with APS do experience migraine. Why? Well, what do we know? APL antibodies are more frequently found in migraineurs than in age-matched controls. But, migraine has a high prevalence and the causal direction of that is quite unclear. You can see that there is generally a higher prevalence of unfavorable cardiovascular risk factors amongst migraineurs. What I would say from experience is that TIA and stroke can trigger off migraines. So, I've seen plenty of people who have had what sounds to be a migraine type presentation, but because they're a bit older or because they've had vascular risk factors or because they've had lingering symptoms that just don't quite make you feel comfortable that this is a migraine, you do an MRI and you find that maybe there's an area of ischemia. And after a stroke, people can have migraines as well. And I think it is true that people with cerebral vascular disease are more prone to migraines. And is that why people with APS are more prone to migraines, because they have higher levels of cerebral vascular disease? Or is it something else? And there are other causes that have been postulated as well. Reportedly, some people do find improvement of their migraines if they've got APS with antithrombotics or anticoagulants. Why is that? We don't know. Is there evidence base for this? Not quite. No, it's more of an anecdotal thing, I think. They're not recommended as primary management. You could speculate whether the addition of antithrombotics and anticoagulants reduces the incidence of cerebrovascular thrombosis, which in itself causes migraine as a secondary phenomenon. You could speculate things about, psychological effects of being on a treatment that reduces your risk, and certainly migraines are definitely linked with psychological factors. I can tell you for sure. I think what I would suggest in patients who have antibodies and migraines is MRI imaging is pretty important, and I think the MRI imaging can help stratify the vascular risk quite well. I think someone who's got migraines and no completely normal MRI, you're less worried about. But in someone who's got, white matter hyperintensities, perhaps lacunar infarcts, and especially if the migraines are ongoing and you repeat the brain MRI in a year or two and things have progressed, I think you would automatically put those people in a higher risk phenotype and use that information to help inform your treatment decisions. So in conclusion, the antibodies are associated with stroke and TIA, and we should test the younger patients as well as perhaps some other patients with other sorts of risk factors for antiphospholipid syndrome. If you do see them together, their etiological contribution does need to be considered, but importantly, alongside the other conventional vascular risk factors, which are so important to manage in conjunction. The role of asymptomatic radiological disease needs to be carefully considered, as well as the significance of migraines. Do these really represent cerebral thrombosis? And overall, and perhaps I would say this, a multidisciplinary approach is the recommended one. Thank you very much. I'd be happy to take any questions in the future by a remote means.
See that, okay. So essentially, Andy has talked to us about management of patients with thrombotic complications of APS, and still warfarin remains the current standard treatment for patients who present with an arterial thrombotic event. So this slide is just really a summary of the DOAC trials and where we're at in terms of guideline recommendations. And so all of the international guidelines currently still say that DOACs are not recommended in the setting of arterial complications of APS. So that's just a reminder, even if someone has single, double or triple positivity, patients with stroke should not have DOACs in that presentation. Again, Andy talked to you a little bit earlier in terms of what evidence we have for intensity of anticoagulation. So patients who need to have anticoagulation with warfarin, what is the most suitable target INR? And I think suffice to say, really, the jury is out. We've got no real firm evidence from any of the studies that have taken place to date which INR is best. Munther Kamashta, who used to work with us at Guy's and St Thomas, published on a retrospective cohort of patients, some of whom had arterial complications of APS, and there was a suggestion in that study that a higher target INR was better in the cohort of patients because they have less risk of recurrence. But this was not really confirmed by the Kreider and Finazzi studies that were also performed a little bit later. But suffice to say that that data, there was some issue in terms of patients that were included. Not all had arterial complications. Some of the recurrences that were reported were patients who had subtherapeutic INRs, and in some cases, patients didn't have persistently positive antiphospholipid antibodies. So I think really it's another area that needs certainly further study in terms of what is the most suitable target INR. The APAS study was another study just looking, it was a nested cohort of patients with antiphospholipid antibodies. And again, that didn't really sort of confirm any difference in patients who had the use of warfarin versus aspirin in stroke presentations. But similarly, they did not have persistent testing for persistent antiphospholipid antibodies. So I think it's really difficult to come to any firm conclusion from the data we have. And also Andy touched on the role of antiplatelets, and I think certainly it's a consideration, but it wouldn't be our approach that somebody would commence both warfarin and aspirin for their first presentation of a proven cerebral thrombotic event. It probably is something you'd consider for somebody, for example, who might have a recurrence or present with symptoms of recurrent TIAs, for example. So back to our case, our young patient with chorea, and I think it's particularly difficult because this technically is a non-criteria manifestation. She has an excess of white matter lesions by definition, and I'm sorry, Dr. Sommerville didn't manage to talk you through white matter lesions, but our neuroradiologist would often say to us that everybody, if you scan the general public, would probably have one of these white matter lesions per decade. So by definition, she has more than you would expect. She's triple positive by definition, and she has quite a high titer of antibodies. So I think certainly for somebody like this, in the absence of another cause, you'd consider warfarin with careful discussion with the patient in terms of bleeding risk, and that you can't guarantee that that's going to make any difference to her symptoms. Similarly, for these patients, and again, Dr. Sommerville alluded to excluding any other cardiovascular risk factors, particularly hypertension. So if you have a young patient who presents with a stroke who has persistently positive antiphospholipid antibodies, their risk of recurrence is another stroke. So I think really for these types of patients, you have to offer warfarin, again, with careful discussion around any bleeding complications. So with that, I'm going to just advance to my last point. So essentially, really important that we're screening for cardiovascular risk factors and that we don't become complacent with these patients who are on indefinite anticoagulation. So, you know, if you're seeing these patients in clinic, make sure that somebody is following up their ongoing cardiovascular risk, particularly hypertension. We've looked at some of the patients in our cohort at Guy's and St Thomas's, and hypertension, which has also been proven in other studies, seems to be predictive for increased risk of recurrence. What the role of hydroxychloroquine is, so in patients who have had thrombotic complications in lupus, for example, hydroxychloroquine seems to have an additional protective effect, and statins, like Dr. Sommerville has alluded to. Finally, just a note to say that there is the ongoing DOAC study, RISAPS. So Dr. Hannah Cohen and her team at UCLH are looking at the role of high-dose rivaroxaban, 15 milligrams BD compared to warfarin, with the primary outcome of change in white matter lesions on MRI. So that's I believe possibly almost finished to recruitment, and we'd be interested to hear on the outcomes from that soon. So thank you very much for your attention, and I will hand back to Beverley.
Hello. So thank you both very much for giving us a flavour of cerebral APS. It's not as easy as it sounds, as Peter said. What I would like to do is to open up the discussion. There are already some questions, and I have given some written answers, but oh, I can't see the questions. So let me go to the chat. Let's just see. I think the first question is for Andy, and it was to ask him about, would you treat unprovoked VTE differently from provoked VTE with APS?
Yeah, so I think it's a good question. I think it's a question that always stumps us. So I think we need to think about when we would do antiphospholipid testing in the first place. So certainly for unprovoked VTE, that's when we would offer it, particularly in the younger cohort and those who have an other autoimmune condition. Those are the patients that we would typically test it for. Now, the current recommendations are that we shouldn't be checking patients who have a clear provoked event for antiphospholipid testing, both by EULA guidance and also other international recommendations. So these tests do get done. Potentially patients who have lupus, the rheumatologist has done antiphospholipid testing on them, and then they have a provoked event. And I think it's a little bit of a grey area, but certainly I would be more guided by the nature of their event as opposed to their antiphospholipid testing in this cohort. Certainly, if you've got a patient who has recurrent provoked events, then that's a different conversation potentially, but a single provoked event, then no, I wouldn't be guided as much by the antiphospholipid testing. But be aware that the patient would need thromboprophylaxis for other high-risk scenarios, so travel, operations, hospitalization.
So I think that we'd agree that if someone had a hospital-associated VTE and they'd had a hip or knee replacement, we'd definitely treat it as a provoked and discontinue anticoagulation. And also in pregnancy or postpartum, if someone had an event, we wouldn't continue anticoagulation, but in their next pregnancy would give them some low molecular weight heparin. But as Andy says, if they've had a long haul flight in the last few weeks, it's a bit of a soft one, isn't it? What would you do for a long haul flight 3 weeks ago and they have a VTE, Andy?
So I mean, it's usually within that month time frame that we consider it as being a risk factor, and I think it's kind of gauging what patient was doing on the flight, how much they're getting up and about, probably having a look at their APS testing to seeing whether there's lupus anticoagulant or triple positivity. I would probably err away from long-term anticoagulation, but some patients may want it, and generally the approach that I find is that if you discuss how to prevent the clots, patients are generally happier to go with that approach, although there is a small number who have these kind of softer indication provoking factors that may want to continue on a low dose of something in the long term. Although when you discuss warfarin as the option, most again are a little bit perturbed by that option.
Okay, coming back to Peter and Karen, you keep mentioning Korea tantalizingly, but don't say how you might manage it. Karen, do you want to talk about that?
Yeah, sure. I think in my case that we discussed, it can be incredibly difficult, right? So you have somebody who comes into clinic and they've got these bizarre manifestations, neurological manifestations, and hopefully Pete will come in and help me out in a minute or two to discuss how he might manage it outside of the non-APS cohort. But in the absence, I guess, where you have properly thoroughly investigated somebody in the absence of any other cause, I certainly find it very difficult if you've got someone who's got a significantly positive antiphospholipid antibody screen not to offer warfarin. There's no firm evidence for that, but I think with the cohort of patients that we've certainly seen come through St. Thomas's, some of them seem to respond. They, they often describe that they have much less frequent episodes and that they feel their symptoms are improved with warfarin. So you certainly have to think about that risk versus benefit of anticoagulating somebody without any particular finding of white matter lesions. So in your experience, women who have a significant pregnancy morbidity, so this is one of the questions in our chat, what is your approach to women who have previously detected antiphospholipid antibodies and have had early pregnancy losses, but then come to clinic and on repeat, their antiphospholipid antibodies appear to have gone away? How would you manage those women?
Thanks, Karen. That's a very good question. Actually, sometimes we see that. So I must say that I sit in a rheumatology clinic, so my cohort might be slightly different to what you would see. So I see often patients with lupus or with mixed connective tissue diseases, rheumatoid arthritis, who then have antiphospholipid antibodies or a syndrome on top of that. So if a patient in my clinic, let's say it's a lupus patient, and they have had previous pregnancy morbidity and the antibodies disappear, as you mentioned, I really think you need to talk to the patient and kind of elaborate on their fears, because a lot of these women have had psychological trauma which associated with these happenings, and then you need to just talk to them and say, well, we know antibodies fluctuate over time, and then I counsel them about the risk that is associated with the treatment. And to me, giving them an aspirin, and potentially if they qualify for warfarin, for heparin as well, then I tell them, this is treatment we can offer you, because as of now, we don't really know what it means when the antibodies disappear. And if I have one negative reading with a previous strongly suggestive history of APS with previous antibodies, then to me, I'm not really in doubt what to do.
Yeah, sure.
Most women would be very, very keen on having the treatment.
Yeah, I agree. I think it's very difficult, if they've been taken through a previous pregnancy that's been successful, and then you're telling them they can't have that treatment anymore. So I think you're right, given the fluctuation in levels, that we have to sort of presume based on their previous history, as long as that's a significant history, that's the appropriate thing to do. And I think equally it can be difficult because often we're referred patients who come from fertility clinics and with a very sort of borderline history, maybe one miscarriage, they don't quite fit the criteria, and they're already on low molecular weight heparin, and by definition, they may have a weakly positive antiphospholipid antibody, so they don't quite meet the criteria. And often in that cohort, we'll say to them that actually there's no firm evidence they need to continue heparin, and that aspirin alone should suffice. So I think at best, each patient really needs a very individual approach, and certainly our clinic slots could probably be a bit longer, because often there is a lot of discussion with these women when they come to clinic, and it's a difficult concept for them to understand. Beverley, how is your connection? Do we have you back?
Yes, I'm here.
Okay,
can you hear me?
Okay, so we were just discussing obstetric cases, and I don't think we have any more questions in the chat. And we have Pete back. Oh, Pete, are you back on track with us now?
I don't know. Am I?
Oh, yes. Okay, great.
There were some questions in the chat. So one was asking about the genetics and the predisposition. I did reply with a written reply just to say, if you have an autoimmune disease, there's a 5% chance that your child will have an autoimmune disease as an adult, and it may be antiphospholipid syndrome or it may be something else. But we do have the odd family with antiphospholipid antibodies in mother and daughter or mother and son, and that would fit in with that in particular. And there was another question on fondaparinux. Now, we don't want to give the game away from the data we're presenting at the ISTH, but Andy, do you want to just quickly say something about fondaparinux here? Because someone was asking about what dose you use. And I did a typed reply saying we'd normally start off at 7.5 milligrams if they had no renal disease.
Yeah, so usually would be guided by the weight, but usually if we start on 10 milligrams, which is generally a large proportion of the UK population, we then go and subsequently monitor their anti-10A levels according to the ACP guidance. So we recognise that usually if we keep the patients on fondaparinux in the long term, they generally have they end up showing higher levels of anti-10A levels. So we generally titrate it down according to what their subsequent anti-10A levels are. And we monitor this with both peaks and troughs, a trough being just immediately before their next dose. We get the patients to stay in clinic with us and we'll check another test at 2 to 4 hours. And I think just to highlight, we do take renal function into account. So with creatinine clearance of less than 50, we do need to be aware that there is increased risk of accumulation in these patients, particularly when we look at the troughs, they appear to be slightly higher. I'd also advocate that these patients would probably avoid giving antiplatelets because we do see that patients who have been on both fondaparinux and aspirin and also with higher dosing. So that's the way that we approach fondaparinux, and hopefully you'll see some more data at ICH.
Thank you. Can you hear me?
Yes,
okay.
We can. Karen, I know Beverley's having problems with her internet. I don't know if you want.
So there seems to be a role of HRT, yes, and transdermal HRT will not affect coagulation. So coagulation, if they're already on oral.
Yeah, perhaps I can take that one because Beverley's connection seems to have gone. Okay, so just the role of HRT in patients who have antiphospholipid syndrome, and I think what we heard from Beverley, she was discussing the transdermal options. So certainly when we see these patients in clinic, we would counsel them that transdermal options such as patches or gels are acceptable. They have very low risk of thrombosis, and certainly they're a very suitable option to consider in patients either who are anticoagulated or not. Oral progesterone formulations are okay as well, because often these women will need both a topical form of estrogen and an oral progesterone in tandem, depending on whether or not they've had a hysterectomy. If patients are not anticoagulated and they want to consider transdermal preparation, they would not specifically need to restart anticoagulation in that setting. Okay, Beverley, are you back? Did you want to use our last minute or two to wrap up if you're managing to have a connection?
Yes, so thank you, Karen. Thank you to all the speakers for a lively debate and a lot of information. Very, very sorry about the internet. I don't quite know where we go from here. Thank you, Joe, for organising it. And I hope everyone who is here got some good information and learnt something. Just to say that this afternoon we've got a symposium on rare diseases and thrombosis. We'll discuss Klinefelters, Klippel-Trenaunay and Bechet's. We've got fabulous speakers, so please come to that too. So once again, thank you to all the speakers. Thank you, Joe, and hope to see you this afternoon.